Good evening, everyone. Am I audible and visible to all of you guys? Please update me in the comment section. Yes. Welcome to the session, part 4. Most of you have revised first 3 parts, and in case any doubts, you guys can ping me on the Telegram. Let's begin with the final part today, the part 4 of Obstetrics and Gynecology, okay? Yes. Okay. So let's begin with the part 4, final part. So let's start with the first question, the drugs for medical abortion. The drugs for medical abortion, as we know that we have already discussed the chapter abortion. As per the MTP Act 2021, it can be, we can go for an abortion up till how many weeks? 24 weeks. We can go up till abortion for how many weeks? 24 weeks. Then previously we have discussed the causes of abortion. For example, it can be chromosomal abnormality, it can be an anatomical cause, or it can be any maternal cause, Yes, good evening to all of you guys. Yes. So be interactive. This is a time to have a final lap. Okay, we'll just revise whatever you have studied so far from last 2-3 months. Okay, so be interactive and keep answering in the comment section. Is that clear to everyone? Yes. So we have discussed so far, as per the MTP Act 2021, that the abortion, we can go up till how many weeks? We can go up to 24 weeks. Then we discuss the different types of an abortion depending upon the PV examination. Okay, we discuss if os is open. If os is open and the products are bulging or the products are hanging, that's going to be your inevitable abortion. If os is open and a patient is giving the history of passage, that's going to be your incomplete abortion. Okay, remember I with open. So I incomplete, I inevitable is going to be os open. Then we discuss about if os is closed and a period of gestation is corresponding to the period of amenorrhea, or period of gestation is corresponding to the uterine size, that's going to be your threatened abortion. Os is closed, patient is giving a full passage, full history, that's going to be a complete abortion. And the abortion with no warning signs, os is closed with a crumpled sac inside, fetal cardiac activity is lost, that's going to be a missed abortion. Then we have already discussed about the treatment for the anatomical reasons. The first one was going to be septate uterus, the anatomical cause for the abortion. We're going for the hysteroscopic resection. Then we discussed the second one, that was going to be, yes, bicornate uterus. We go for the Stressman metroplasty. And the last one, incompetent cervix. Comment down, what is the cerclage that is used in an incompetent cervix? What is the cerclage that is used for incompetent cervix? What is the most common cerclage that we use? Everyone? Yes, sir, the most common one, very right. The most common one that we use is going to be McDonald cerclage. That's going to be McDonald cerclage, applied at 12 weeks and removed at 37 weeks. Is that clear? Okay, this was just a recap from the previous, part 3. Okay, we have discussed till now all this stuff about an abortion. Now the main question that they usually can ask is a medical abortion drugs. So how long we can go for the medical termination of pregnancy? Okay, now if we talk about a medical termination of the drugs, the two drugs that we use is going to be misoprostol and mifepristone. Very good, most of you are correct. Yes, what will be the dosage of the drugs? The first one is, that's going to be mifepristone, we are using on day 1. What will be the dosage? That's going to be 200 mg. And misoprostol, prostaglandin E1, that's going to be 800 micrograms after 24 to 48 hours. Yes, this is going to be the last session. Okay, this is going to be the last session for OB-GYN. Followed by this, we go for pathology around 27th. Okay, and then we'll go for an pediatrics around 30th. Okay, next, now sir, as per if we talk about a medical termination of the pregnancy, best methods, if it's less than 7 weeks, we are going for medical abortion. Less than 7 weeks, we are going for medical abortion. Okay, if I talk about 7 to 12 weeks, we are going for suction and evacuation. Okay, that is the best. If a female is coming less than 7 weeks, you go with the medical abortion. If it's between 7 to 12, you go with the suction and evacuation. And more than 12 weeks, prostaglandins are the procedure of choice. More than 12 weeks, prostaglandins we use. Is that clear to everyone? Now, as per the government of India says you can go for the medical termination of pregnancy till 7 weeks, but WHO says you can go up till 9 weeks. Now, what exactly is the difference? The earlier you go, the better it is. If I talk about till 7 weeks, it's going to be around 99% effective, and if I talk about 9 weeks, it's going to be around 95% effective. That's going to be your mifepristone and misoprostol. Now you exactly know, so the dosage is 200 mg of mifepristone and misoprostol of 800 micrograms. Now what exactly these two drugs do? If I talk about mifepristone, it has an anti-progestin action. Okay, it blocks the progesterone. Now you already know that the hormone that's used to maintenance of the pregnancy is going to be progesterone, and when the progesterone is blocked by this mifepristone, it will kill the fetus. Followed by that, after 24 to 48 hours, you are going to give which drug, bacho? You are going to give misoprostol, sir. We are going to use misoprostol. Now misoprostol belongs to the which class of drug? That's going to be prostaglandin E1. We have already discussed this prostaglandin E1 in the treatment of which condition? Postpartum hemorrhage. And what exactly will this PGE1 do? So it will expel the fetus out. How much mifepristone you will use? So we are going to use 200 mg. And how much is it? Can be used 800 micrograms. Now some books you will see, sir, it's already written 400 micrograms. This 400 micrograms is when first 7 weeks you use 400 micrograms. If 7 to 9 you use 800 micrograms. It can be used orally, okay, it can be used vaginally as well, okay, or sublingual as well. Is that clear? Is that clear to everyone? Yes, it can be used oral, buccal, also vaginally. Per vaginal we can give these drugs. Which drug? Misoprostol. Yes, mifepristone only oral. It can be used oral. This one can be used oral, buccal, per vaginal. Okay. No, it can be used, Rituraj, it can be used till first 9 weeks. Can be used till first 9 weeks. Is that clear to everyone? So the answer for this question is going to be mifepristone 200 mg, misoprostol 800 micrograms. The first drug blocks the progesterone. The second drug expels the fetus out. It expels the fetus out. Chalo. Let's move to the next question. A 30-year-old primee attends the antenatal clinic at a period of amenorrhea of 35 weeks. A 30-year-old lady is coming with a period of gestation or period of amenorrhea of 35 weeks pregnant. She has a single fetus in the breech presentation. So which presentation is that? Remember, 35 weeks amenorrhea. She is in a breech presentation. She just attends an antenatal clinic. There is nothing emergency, no emergency. Ultrasound scans confirms the presentation. No other abnormalities detected. What is the next step in the management of a normal vaginal delivery? So the important stuff, important question, important things to understand in a question is that what is the presentation of a patient? Always remember that. Okay, now I'm saying that a female is coming to you. She is a confirmed breech presentation at how many weeks? Preterm, 35 weeks. Okay, right now nothing else is there, no abnormalities detected. Now what will be the next management? Okay, now let's discuss about a presentation. Now what exactly is presentation? Okay, now what exactly is presentation? It means the pole of the fetus lying on the lower segment. Which part of the fetus is lying on the lower segment? That is going to be your presentation. If a head is in the lower segment, I call it as cephalic presentation. If a shoulder is under lower segment, I call it as shoulder presentation. If a breech is in the lower segment, I call it as breech presentation. Now let's write pole of the fetus. What is presentation? That's going to be pole of the fetus. Lying on lower segment. pole of the fetus lying on the lower segment. Okay, now cephalic presentation. So what is cephalic presentation? It means head is at the lower segment. It means head is at the lower segment. So if a head is touching the lower segment, I call it as cephalic presentation. Next one is going to be shoulder presentation. If shoulder is at lower segment, I call it as shoulder presentation, or I can also call it as transverse presentation. I can also call it as transverse presentation. I can also call it as transverse presentation. Clear? Now, if breech is at the lower segment, I call it as breech presentation. If breech is at lower segment, I call it as breech presentation. I call it as breech presentation. Now, depends upon a period of gestation and depends upon a lie, whether it's a vertical lie, whether it's a transverse lie, number one thing. Second, presentation. Number third is going to be your labor. If a patient is in labor, what will be the management? Patient is not in labor, what will be the management? What will be the management? Clear? Now, if a cephalic and breech presentation has a vertical lie, now simple mechanism, guys. If head is in the lower segment or a breech with a vertical lie, is in a presentation, what is the type of delivery you're going to do? You're going to go for normal vaginal delivery. Simple. Okay, you have a patient coming to you with a vertical lie. So what is the mechanism? Normal vaginal delivery. Is that clear to everyone? You're going for normal vaginal delivery. Now, if a patient is coming to you with a shoulder presentation and patient has transverse lie. Now, patient is coming with a shoulder presentation with a transverse lie like this. Okay, can you deliver with a normal vaginal delivery? No, you go for the cesarean section. You go for a cesarean section. Is that clear to everyone? Is that clear to everyone? Yes. So if a patient is in a vertical lie, whether it is a cephalic presentation in which a head is in the lower segment, or whether it is a shoulder breech presentation with a vertical lie, the mechanism to deliver is just normal vaginal delivery. Now next point is, if a patient is coming to you with a transverse lie, ऐसे आ रहा है बच्चा, can you go with the normal vaginal delivery? No. Okay, so you go with the cesarean section. Okay, now if a question mentions patient is in term pregnancy, what is term pregnancy? Around 37 to 42 weeks, and uterus is relaxed, woman is not in labor, what we are going to do? So remember, if a patient is in term pregnancy 37 weeks onwards and she is not in labor, the condition how we will deliver, write it down. At 37 weeks, we have two scenarios, sir. At 37 weeks, so female is coming to gynae clinic, obstetrics and gynecology clinic. She's in a term pregnancy at 37 weeks, and she's saying that she has no contractions or she's not having any pain. That means she's not in labor. So the transverse lie, we can change it to the vertical lie with the help of an external cephalic version. What are we going to perform, Acho? So we are going to perform external cephalic version. Now what exactly is this external cephalic version? From the outside, I will turn the baby from transverse lie to the vertical lie. Is that clear? From transverse to vertical, I will move. This is called as external cephalic version. But you can only do external cephalic version when she is not in labor and it's a term pregnancy. Is that clear? Now, sir, if a female is coming to at 37 weeks, now at 37 weeks she is coming, but female, she is in labor. So how to deliver if she is in labor? So I'm going with cesarean section. Is that clear? Now at 37 weeks she is in labor and I'm going to go for cesarean section. Is that clear? Now a patient is there at 32 weeks or 34 weeks, up till 34 weeks. Now you already know the level of an amniotic fluid is maximum around 30 to 34 weeks. Okay, even if you go for an external cephalic version at that point of time, when the amniotic fluid levels are more than 1000 ml, what will happen? The baby will change its position. Okay, even if you go for an external cephalic version, you move it to the vertical line, again due to the increased amount of amniotic fluid, the baby is going to change the position. So external cephalic version is not done around 32 to 34 weeks. Why? Because amniotic fluid keeps increasing and baby will change its position. Clear? Okay, so around 30 to 32 weeks, what you have to do, just wait till the term, and if in the term she is not in labor, go with the ECV, and if a patient is in labor, you go with the cesarean section. Is that clear to everyone? Yes. Now answer the given question. A 30-year-old female at 35 weeks of pregnancy, she's in a breech presentation, no other abnormality seen, she's not in labor, what is the next management? Answer the question now. You already understood the mechanism. Now a patient of a breech presentation or the transverse lie in the term pregnancy, in a labor, you go with the cesarean section. Not in labor, you go with the external cephalic version. And if she comes around preterm, what will be the management? If there is nothing, no wrong, no contractions, no labor, what will be the management? Write down your answers in the comment section. I'm checking, guys. A, how come A, before 41 weeks, you're saying induce a labor if not delivered by 41 weeks, but before 41 weeks, what comes there? Why you will wait till 41? Yes, exactly. The answer is going to be C. You perform an external cephalic version at how many weeks? At 36 weeks. Okay, at 36 weeks. Is that clear? Very good. So we are going to perform the what? We are going to perform an external cephalic version at 36 weeks, so that from a transverse lie, this is the breech, that is a transverse lie, will change into the vertical lie, and then we are going to deliver. The patient with the normal vaginal delivery. Is that clear? Is that clear to everyone? Yes, all of you are correct. The option answer C. Now let's understand a breech. In terms of a breech, what is the main question that they usually ask? The maneuvers. What is the main question that they usually ask? The maneuvers. So you already know, so the breech is defined as when the breech is touching the lower segment. Okay, now this breech can have a vertical lie and a transverse lie, and if it comes in a term pregnancy with a transverse lie, in a labor we are going with a cesarean section. If not in labor, you're going in an external cephalic version. Now we have different types of breech. We have a frank breech, we have a complete breech, and we have a foot-link breech. We have frank breech, we have complete breech, and we have foot-link breech. This frank breech is also called as extended breech. Okay, this is going to be the most common one. Okay, and complete breech is also called as flexed breech. Okay, now if I talk about these two, complete and frank breech, they can be delivered with the help of normal vaginal delivery. How do we deliver these two? We go for a normal vaginal delivery. But if I talk about this foot-link breech or an incomplete breech, how do we deliver? We're going with cesarean section. Okay, now to deliver the breech, we need a different types of maneuvers. Now to deliver this frank breech or complete breech, we need a different types of maneuver, and that's the main question usually from your recent NEET PG exams. That's the question they ask. They will give you the picture of this maneuver and tell you what exactly is this maneuver used for, or what organs are being delivered with the help of these maneuvers. If I talk about the first one, breech delivery, best type of breech for the normal vaginal delivery is going to be frank breech or extended breech. That's going to be frank breech or extended breech. Okay, then for extended legs, for the legs we use a maneuver called as Pinard's maneuver. Sir, for legs we use a maneuver called as Pinard's maneuver. Okay, then for the extended arms we use a maneuver called as Lauset's maneuver. For extended arms we use a maneuver called as Lauset's maneuver. Now after coming head, we use different maneuvers and of types of forceps. Okay, we use a technique called as jaw flexion and shoulder traction. It's also known as Mauritius simile weight technique. Okay, then we use the outlet forceps can be used called as which forceps, bacho? So they are called as Piper's forceps. And we use Burr-Marshall technique or Retigen maneuver. This is going to be your Burr-Marshall maneuver. Okay, after coming hand, first one, let him hang until you can see the hair at the back of his neck. Okay, once the full body is delivered, now only head is there. Okay, once you see this hair, okay, just wait. Okay, let him hang. Then the second one, hold his feet. You're holding the feet and free his mouth and suck him out. Okay, you swing the baby and the head is clear. Okay, first of all, the baby head is visible. Once the hair on the neck is visible, then you hold the feet, free his mouth and suck him out, and then swing his head clear. That's going to be your which one? That's going to be your Burr-Marshall maneuver. This is your NEET PG PYQ this time. They just gave this picture, same picture they gave, and asked which type of maneuver is this? Retigen maneuver, Pinard's maneuver, Burr-Marshall maneuver, or Mac-Roberts maneuver. What's your answer going to be? Your answer is simple. It's going to be Burr-Marshall maneuver. Then if I talk about a Retigen maneuver, the moderate upward pressure is applied to the fetal chin by the posterior hand covered with a sterile towel, while the suboccipital region of the fetal head is held against the symphysis. This maneuver is going to be the Retigen's maneuver. Then the forceps after coming head, the forceps are called as Piper's forceps. Okay, and this technique, that's going to be your jaw flexion and shoulder traction technique. It's going to be your simile weight technique. Is that clear? So all these four things, whether that's going to be a Burr-Marshall maneuver, whether that's going to be a Retigen's maneuver, whether that's going to be a Mauritius simile weight technique, or Piper's forceps, Pinard's maneuver, Lauset's maneuver, that's going to be your important upcoming questions. Okay, so you already know a female coming at preterm with no indications in labor, with no complaints, with no contractions, she's not in labor, you're going with an external cephalic version. Is that clear? Breech part is clear now, bacho? Yes, write down in the comment section all the people who are watching. Is that clear? Yes. Yes. Okay. Next one. A primary gravida is brought home by her relatives just after 1 hour. Okay, after the vaginal delivery of a full-term healthy infant. The baby is doing well. On examination, the patient is hypotensive, hypoxia, and has a disseminated intravascular coagulation. Okay, which of the following is the most likely diagnosis? Okay, now we have already studied in our main classes that a triad of hypotension, hypoxia, and a coagulopathy is going to be a, what will be the answer? Write down in the comment section. What will be the answer? So that's going to be a amniotic fluid embolism. Okay, I've already discussed a patient coming to you with the complaints after the delivery, patient is into the shock and patient has hypoxia, hypotension and coagulopathy. This is a classical case of an amniotic fluid embolism. Now if we discuss, we have already discussed these three possible scenarios. After the delivery, if a patient is going into the shock, normally if a patient is going into the shock, the most probable diagnosis can be postpartum hemorrhage. Okay, and if a patient is going into the shock immediately after the delivery, that means within no time patient is going into the shock, your answer is going to be uterine inversion. Your answer is going to be uterine inversion. We have already discussed that in case patient is going immediately into the shock, that's going to be uterine inversion. The first shock in the uterine inversion, that's going to be patient is going into the neurogenic shock. Okay, and if they mention, if the examiner will mention that what is the most common cause of the death in case of a uterine inversion, then your answer is going to be hemorrhagic shock. Your answer is going to be hemorrhagic shock. Two scenarios. First shock is going to be neurogenic, followed by that hemorrhagic, but the most common one causing a death is going to be a hemorrhagic shock. Number first thing is going to be resuscitation. Number second, in uterine inversion, you put the maneuver with a fist called as manual reposition of the uterus, called as Johnson's maneuver. Then we have other methods as well. If everything is failed, after even relaxing the uterus, you are not able to push the uterus back to its position, you go with the surgical procedures called as Huntington and Haltian's procedure, Okay, and if a patient is going into the unexplained shock, the answer is going to be, sir, amniotic. Answer is going to be amniotic fluid embolism. The answer is going to be amniotic fluid embolism. Is that clear? Now what exactly is this amniotic fluid embolism? Write it down. It's an intravascular invasion. It's an intravascular invasion of maternal circulation. By amniotic fluid and its contents. Leading to DIC. That's going to be your amniotic fluid embolism. The diagnosis tried, you have already in the question given. So patient will have hypotension, patient will have hypoxia, and patient will have coagulopathy. This is a classical triad of which amniotic fluid embolism. So hypotension, hypoxia and coagulopathy is given. Your answer is going to be amniotic fluid embolism. Clear? Now if a patient is coming with a fracture of a long bones, okay, F is fracture, F is fat embolism. Remember, fracture of long bones, fat embolism, the name of the criteria is going to be GERD criteria, G-U-R-D, GERD criteria. Patient with a deep venous thrombosis, or a patient having a history of a pelvic surgery like total knee replacement surgery, total hip replacement surgery, the answer is going to be pulmonary embolism. So remember these two scenarios: femur fracture, long bones, fat embolism; deep venous thrombosis, TKR, pulmonary embolism; amniotic fluid and its contents, pregnant lady, amniotic fluid embolism. That's going to be amniotic fluid embolism. Okay, now it's clear. Let's move to the next question, guys. A 12-year-old is brought to the OPD by her mother. She's concerned that she is shorter than her peers. On evaluation, which of the following would you expect to found? Okay, short stature. Okay, now what will be the answer for this question? Ultrasound showing streak ovaries and a small uterus, echo showing a tricuspid stenosis, there is a hepatomegaly and altered echo texture, or there is a patient having a single kidney. Very easy one and repeated one. Okay, a 12-year-old girl is brought to the OPD by her mother. She is concerned she is shorter than her peers. On evaluation, which of the following would you expect to find? Exactly, very good. You are expecting that this is a case of a Turner syndrome, and in Turner syndrome, ultrasound shows the streak ovaries and the small uterus. The ultrasound shows a streak ovaries and a small uterus. The echo is showing tricuspid stenosis. the heart problem that is also the cardiac anomaly that is associated with the patient of a Turner syndrome is going to be bicuspid aortic valve stenosis, followed by that coarctation of aorta. Now let's discuss about a Turner's syndrome. Let's discuss about Turner syndrome 45XO. Okay, now if we talk about the Turner syndrome, first of all, it's the most common cause of primary amenorrhea. It's the most common cause for primary amenorrhea. If we talk about the features of a patient having a Turner syndrome, first of all, it's going to be short stature. Remember, patient is going to have a broad chest. We also call it as shield chest. Okay, there are wide space nipples. Okay, and the congenital heart disease that's going to be associated, most common if they ask, your answer is going to be bicuspid aortic valve stenosis, then coarctation of aorta, COA. Okay, COA. Remember, the patient having a female having a Turner syndrome have increased chances of metabolic syndrome. Now this metabolic syndrome, 5 components we have already discussed in the chapter of PCOD. Okay, then a patient can have an abnormality in the kidney. Along with that, patient will have a knee deformity. Okay, patient will have a brown spots, patient will have a pubertal failure, there will be a short fourth metacarpal. Okay, and patient will have a low hairline as well, and broad short or the webbed neck. The highlighted ones are the main ones. Patient will have a shield chest, short stature, they'll have a streak ovaries. Okay, and the question that has been asked in your examination, which of the following is incorrect about the Turner syndrome? Remember that very, very, very important one, sir. There is no mental retardation. No mental retardation seen in which syndrome? No mental retardation seen in Turner's syndrome. Is that clear to everyone? Is that clear to everyone? Yes, write down in the comments. Clear? We're going a bit faster because we'll complete by today all the remaining part. Okay, and most of you have revised, and it's a rapid revision session, so speed should be faster. Next. A 28-year-old woman has been on OCPs for 5 months. She presents to the OPD with a 6-week amenorrhea and UPT is positive. Which is the most accurate method to determine the gestational age in this woman? Okay, the most accurate method in the first trimester is going to be crown rump length on ultrasound. The answer is going to be crown rump length on ultrasound. Okay, because she has been on OCP, she does not remember the dates as well. UPT is positive, so the best method to know in a first trimester is going to be crown rump length. The best one is going to be crown rump length. Is that clear? Now the best parameters in first trimester, in second trimester, and in third trimester. If I talk about the first trimester, we're going for crown rump length. That's CRL. Okay, second trimester we go with biparietal diameter. That's going to be BPD. Third trimester we go with the femur length. We go with the femur length. And if we talk about the overall best, your answer is going to be CRL. Your answer is going to be CRL. Is that clear? Now Other options were counting to 80 days from LMP, counting to 56 days from UPT positive, examination of the uterine size. No, they are not more accurate. Okay, yes, we can calculate EDD with these dates. Okay, how to calculate the estimated date of delivery? You have a formula called as Nagli's formula. You have a formula called as Nagli's formula. Okay, this Nagli's formula is only used when you have a normal cycles, when you correctly remember the dates, number one. Number second, when you have a normal cycles, you have a regular cycles, then only you can use the Nagli's formula. You can, from LMP, you can add 9 months plus 7 days. You can add 9 months plus 7 days. Is that clear? Now if a patient is having LMP, what is the date today? The date is 23rd of December. What will be the EDD? Comment down. What will be the EDD? What will be the EDD? Yes, if a patient is having an last menstrual period on 23rd of December, calculate the EDD. Comment down the answer. Add on 9 months plus 7 days. What will be the answer? If they mention that LMP is 23rd of December, add on. That's going to be 30th September. Okay, 23 plus 7 is 30 plus 9 months, September. So September 30. That's going to be September 30. Is that clear? Is that clear? But sir, this is only for patients having normal cycles. But if a question mentions that a cycle is 30 days, if the question mentions that the cycle is 30 days, what will be your answer? You will add on 9 months plus 7 days plus 2 days, because 28 days is the normal cycle, so you add on 2. If eventually they will mention 26 days, you subtract 2. You subtract 2. Is that clear? So that was about which formula, bacho? Nagli's formula. That was about Nagli's formula. 9 months plus 7 days. First add on 7 days, then add on 9 months. Okay, now if we talk about fundal height, I have a simple mnemonic for the fundal height, PUX. How do you remember this PUX? P at 12 weeks, it's going to be pubic symphysis. P, that's going to be pubic symphysis. At how many weeks? At 12 weeks. At 20 weeks, that's going to be a lower border of umbilicus. Lower border of umbilicus. 24 weeks, it's going to be upper border of umbilicus. And at 36 weeks, it's going to be a cephisternum. It's going to be cephisternum. Okay, what do we need to study for FMGE? Whatever we are studying, whatever I'm teaching, that's all. But first go through a primary notes, whatever your sources. Okay, then this right now we are going with a quick rapid revision, okay, of all the high topics. If you have not started yet, if you're someone who is still in the pre-final or the final year, take a proper source, take a proper platform, go with the course, read the notes carefully, solve the MCQs, don't delay, start up early, okay, and then solve the tests, QBank, and then in the end you can go and watch these rapid revisions. Okay, clear? Chalo guys, let's come back on the track guys. Good evening. Okay, we are just few days, before it was months, now it's just few days. Okay, around 20 days, 19-20 days. Okay, so I hope you all are revising, you all are solving PYQs, PYTs. Put right now the main focus should be on the previous year questions and the previous year topics. Clear? Chalo. So sir, the fundal height, simple mnemonic, pux, P-U-X, that's going to be 12, 24, 36. 12 is pubic symphysis, 24 is umbilicus, U for umbilicus, U for upper border of umbilicus. So upper border पे 20 क्या आएगा, lower border of umbilicus, and X 36 for C sternum. X is 36, that's going to be C sternum. Okay, that's going to be your fundal height, pux. Okay, उसके बाद we're going for the triple test and the quadruple test. So what is the question that they last? Out of which of the following is not a component of a quadruple test? Out of which of the following is not a component of a triple test? So triple test, what are the components? We are going to have a beta HCG, plus you're going to have alpha fetoprotein, plus we're going for estriol, beta HCG, alpha fetoprotein and estriol. Okay, is that clear? Now if I talk about a quadruple test, we are going to have triple test plus you're going to have inhibin A. You're going to have triple test plus inhibin A. Okay, they will ask out of which of the following is not. In options they will give inhibin B. B is not a component of a quadruple test. That's going to be inhibin A. Now my question to you guys, inhibin is a tumor marker for which ovarian tumor? Inhibin is a tumor marker for which ovarian tumor? Anyone in the comment section? Inhibin is a tumor marker for which ovarian tumor? Also tell me, alpha fetoprotein is raised in which ovarian tumor? Most of you have revised. Yes. Inhibin is going to be granulosa cell tumor, remember that. Estrogen screening tumor, granulosa tumor with the call axonal bodies, and alpha fetoprotein is going to be your yolk sac tumor. Alpha fetoprotein with yolk sac tumor, inhibin with granulosa cell tumor. Clear? Can we move to the next question? So chorionic villus sampling, we go for the CVS sampling around 10 to 13 weeks. Okay, and for the chromosomal abnormalities we go for the CVS, and amniocentesis we go around 16 to 18 weeks to check neural tube defects and all. Clear? Okay, if we go before 10 weeks for CVS chorionic villus sampling, it will cause the limb abnormalities, limb decompression, limb abnormalities, limb deformities. Okay, next question now. A 25-year-old female with a history of 2 weeks of amenorrhea. Now a female is coming to you with the 2 weeks amenorrhea. She came in an emergency with the complaints of scanty vaginal bleeding. So she's coming with a scanty vaginal bleeding. On examination there is no adnexal mass noted. HCG was 1400 international units. On USG uterus was bulky and the trilaminar endometrium is seen. The patient's vitals are stable. What is the next management? Write down in the comment section, guys. A female with a history 2 weeks of amenorrhea, no adnexal mass is noted. USG uterus, on USG uterus is just bulky. There is no gestational sac seen. Neither the pregnancy is in the tubes. Okay, at 2 weeks you don't know. Okay, so at 2 weeks you are checking the HCG levels. They are 1400 international units. So what is the next step? What will be your answer? Chalo. Now first of all, this trilaminar appearance, my dear students, it is seen during the late follicular phase. So this is seen during the late follicular phase. Okay, now you know these lines, these two lines, okay, these two lines, they are the functional layers of endometrium, and with the middle one central hypoechoic line, okay, with a central echogenic line. So these two lines, okay, these two lines blue one. Okay, they are the functional layers of the endometrium, and one echogenic line in the center, so giving appearance of a triple laminar appearance, and this is seen during the late follicular phase. So this does not tell me whether there is an ectopic pregnancy or intrauterine pregnancy. So the layers that can tell me about whether this is going to be intrauterine or an ectopic pregnancy, that's going to be double decidual sign by parietalus and capsularis, but don't confuse yourself with this triple trilaminar appearance. Okay, after that, what is the next step right now you can do? When she's only 2 weeks amenorrhea, you will repeat the beta HCG after how many hours? After 48 hours. The best way to decide now is going to be first, so we'll repeat the beta HCG after 48 hours. So after 48 hours, if the beta HCG is doubling, after the 48 hours, this is going to be intrauterine pregnancy. This is going to be intrauterine pregnancy. After 48 hours, if the beta HCG is not doubling, it takes around 5 to 7 days to double. That is going to be your ectopic pregnancy. That is going to be your ectopic pregnancy. Is that clear? So beta HCG doubling in 48 hours, intrauterine pregnancy. Beta HCG doubling in 5 to 7 days, that's going to be your ectopic pregnancy. Now if I talk about serum progesterone levels more than 25, that's going to be your normal pregnancy or intrauterine pregnancy. Less than 25 is going to be your ectopic pregnancy. That's going to be your ectopic pregnancy. Now management of this ectopic pregnancy, depending upon the beta HCG level less than 5000 and ectopic mass size less than 4 cm, that's going to be medical management. More than that, that's going to be surgical management in terms of a unruptured ectopic pregnancy. But if there is a ruptured ectopic pregnancy, you have only one management, that's going to be total salpingectomy. Okay, already discussed the management of an ectopic pregnancy, causes of an ectopic pregnancy, site of an ectopic pregnancy, and the criteria for the different types of ectopic pregnancy in the part 3. Okay, now double decidual sac on the USG. The outer layer is decidua parietalis. It's formed by decidua parietalis. Okay, inner layer is decidua capsularis. Decidua capsularis, and it indicates intrauterine pregnancy, and this is going to be your double decidual sign. Okay, that's going to be your double decidual sign. Okay, decidua parietalis and capsularis, decidua parietalis and capsularis. Is that clear? Okay, and if this is present, it indicates intrauterine pregnancy. Okay, and if it is not present, that means there is going to be ectopic pregnancy. Next question, guys. A 24-year-old woman who is being treated for infertility with HMG, human menopausal gonadotrophin, she came with a complaints of sudden abdominal pain. So patient is a case of an infertility. She's been given injections of human menopausal gonadotrophin. Now she's complaining of a sudden abdominal pain, nausea and vomiting and breathlessness. The finding on the ultrasound is shown below. What is the most likely diagnosis? Very easy and repeated one. What will be your likely diagnosis, bacho? What will be the likely diagnosis? Yes sir, the likely diagnosis is going to be ovarian hyperstimulation syndrome. The diagnosis is going to be ovarian hyperstimulation syndrome, OHSS. Now sir, first of all you will see big follicles in the central, okay, beach mein. Okay, if they are on the periphery, that's the diagnosis of a polycystic ovarian disease. First thing. Second thing, PCOD patient will have a case, he will have a complaints around acne, hirsutism and ovulation. और इसमें क्या देंगे? What they will give? They will give a patient having infertility, patient having human menopausal gonadotrophin or injections of FSH. So why these injections are given? The reason these injections are given to stimulate the follicles so that more follicles will be recruited on the day 14th. On day 14th, what we do? We go under the general anesthesia and take these follicles out. Then we fertilize them outside and then put the embryo back in the uterus. Okay, now while stimulating these follicles so that more and more should come out, while stimulating the ovaries, what is happening, guys? Sometimes it causes a complication, it causes a syndrome called as ovarian hyperstimulation syndrome. It causes ovarian hyperstimulation syndrome. Is that clear? Is that clear to everyone? So what are the symptoms? Abdominal pain, nausea, vomiting, breathlessness. Clear? Chalo. Now, ovarian hyperstimulation syndrome, it's characterized by the multiple ovarian follicle cysts accompanied by increased capillary permeability. It happens most often as a complication of ovulation induction therapy. I told you already, when we try to induce the ovulation, we go for the ovulation induction therapy with the help of an human menopausal gonadotrophin, or we go with an FSH injections, and that's why this complication occurs due to the stimulation of a vascular endothelial growth factors VEGF expression in the granulosa lutein cells by HCG. Okay, then the HCG is increased, patient is vomiting as well because of the increased beta HCG. Okay, that's going to be your ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. Is that clear? So the only question that they ask from this is going to be the image. Okay, so remember the radiological image. But if I talk about PCOD, अगर PCOD की बात किया जाए, so that is going to be on the periphery. Is that clear? This image is going to be PCOD, and the other one that I showed you guys, that's going to be a ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. Next. Next one. Now the drug of choice. If a question is mentioning drug of choice for an ovulation, if simple an ovulation is asked, you go with the clomiphene citrate. If they mention an ovulation in case of a PCOD, then the drug you use is an aromatase inhibitor called as letrozole. The drug is a letrozole. If asked drug of an ovulation due to the pituitary ablation, your answer is going to be HMG. Your answer is going to be HMG. Okay, due to the Kalman syndrome, there is a hypothalamic lesion, okay, due to which patient is having anosmia. In males there is having azoospermia. In females there is an ovulation. The drug we use is pulsatile GnRH. And an ovulation for OHSS in IVF, we use human menopausal gonadotrophin. Is that clear? Is that clear to everyone? Yes? Is that clear to everyone? One-liners. So remember, in case of PCOD, we use a letrozole, and letrozole is a which class of drugs? And that is aromatase inhibitor. That's going to be your aromatase inhibitor. Okay, if generally they ask what is the drug that we use in a case of a non-ovulation, your answer is going to be clomiphene citrate. Your answer is going to be clomiphene citrate. Done? Chalo. Next. A 30-year-old woman presents to your OPD with complaints of foul-smelling discharge. For the past 3 weeks, on examination, discharge is thin, creamy, white, and fishy odor on addition of 10% of KOH. What is the most likely cause? So a creamy discharge, foul-smelling creamy discharge, types of vaginitis, and the most common one, okay, in terms of a creamy white discharge, the answer is going to be bacterial vaginosis. Okay, and the bacterial vaginosis is caused by A, B, C, D: Trichomonas, Candida, Gardnerella, or Chlamydia. Yes, what is the causative agent for bacterial vaginosis? The causative agent for bacterial vaginosis is, write down in the comment section, guys. Very good, that's going to be Gardnerella. Answer is going to be Gardnerella. Your diagnosis is going to be bacterial vaginosis. Your answer is going to be bacterial vaginosis. Okay, A, how can A be the answer? A will cause Trichomonas vaginalis, trichomoniasis. Okay, A is trichomoniasis. There is a greenish discharge, okay, and this is a creamy discharge. So B, how can B will cause a curdy discharge. B will cause which discharge? C for candida, C for curdy, C for cheesy discharge. Chalo, let's understand all of this. First of all, candidiasis. Remember, candidiasis will cause which type of pH? Candidiasis will have a which type of pH? That is going to be acidic pH. Candidiasis will have which pH, guys? Acidic pH. And it is caused by the fungi, that is a dimorphic fungi, Candida albicans. Candida albicans. Okay, and what write it down. And mycelia is